let's get started on our second EKG case review. I hope that you enjoyed our first one that we did a month or so ago, and I'm going to try to put these out at regular intervals. First thing we're going to do is review some subtle changes, kind of like we talked about in our last video, but we've had more cases that were very interesting, and I think that we should review those. And then we're going to talk about how you diagnose STEMI in a left or right bundle branch block, or can you even diagnose STEMI in a left or a right bundle branch block. And if you haven't learned any updates in the past few years, then I think you might be surprised by what we're going to talk about today. So, first EKG. Let's take a look at this EKG. Pause it if you want to. I'll give you a few seconds to look at it and think about what you're seeing. Okay, so you'll see that it meets ST elevation MI criteria per the computer, but does it really? So this was one EKG in a series of multiple EKGs that would give the computer interpretive statement of meets ST elevation MI criteria, and then some would not. The paramedic, at their discretion, decided to go ahead and activate the cardiac cath lab because, generally it's better to err on the side of caution. But what I really want to point out on this EKG is that there is a lot of artifact. The computer interpretive statement is generally good if the tracing is clean. So if there's a flat baseline or a clean baseline and it says that it meets ST elevation MI criteria, then it probably does. But if there's artifact, you have to take that with a grain of salt and try to get a clean EKG. So this patient ended up not having a STEMI. This was another very interesting case of a patient that presented with classic signs and symptoms of ACS. So they were having classic heaviness in their chest, sudden onset while doing an activity, your typical presentation. Now, if you have seen our last EKG video, and you should have, you'll notice that there are some pretty big T waves in the inferior leads. Now, they're not big in isolation, but they are big in relation to the size of the QRS complex. So you'll see that we have a very tall T wave here in lead 2, a very tall T wave in lead 3. Now look how tall this T wave is relative to the size of the QRS. So the T wave is actually bigger than the QRS, but you also have a few more findings. You have T wave inversion in AVL. Now, T wave inversion in AVL is never normal unless the patient has high voltage, so very big QRS complexes, or a left bundle branch block. If they don't have either of those, then you have to ask why, and you need to explain why there's T wave inversion in AVL. And in this case, the most reasonable explanation is that the patient's having an inferior STEMI. Okay. Now, if you're still not sure, look at the anterior leads, because remember in the past video, I'm pretty sure I said that inferior and posterior MIs generally occur simultaneously and not in isolation. We do have some anterior ST depression here that is below the baseline, but you also have tall R waves. Now, the tall R waves are actually reciprocal changes to posterior Q waves. So the patient is having an inferior posterior MI. They didn't initially activate the cath lab, but they did have a high index of suspicion and took EKG after EKG after EKG. And finally, they got to the ER. They were waiting on a bed, and lo and behold, they obtained the 10th EKG, and this was the first EKG to have truly any dynamic changes that were really appreciable. And now it is, quote, diagnostic. So they whisked the patient to the cath lab, and they ended up having a coronary occlusion. Now, I actually debriefed this call with some folks from the facility and the cardiologist, and the cardiologist said, you know what, if you presented this EKG and you explained the patient's symptoms that they were classic signs and symptoms, he said, this EKG is pathognomonic for a coronary occlusion, even though it doesn't meet the arbitrary millimeter criteria. So he said, I would have cathed this patient right away, even though it doesn't meet the traditional millimeter criteria. But I told him that I said, generally we recommend that our providers, if they have a subtle EKG that doesn't meet traditional millimeter criteria, maybe one with hyperacute T waves, I said we recommend that they consult the ER physician, explain the EKG, or try to get them a picture of the EKG and say, would your cardiologist want to cath this patient now or later? And he said that that was a reasonable approach. So just a quick review of posterior STEMI. So remember, generally, posterior STEMIs don't occur in isolation, but sometimes they do. And we actually had a case of that. So what you're looking for is horizontal ST depression in the anterior leads, and it's going to look something like this: upright T wave and a large R wave. Imagine a carousel horse. It kind of looks like a carousel horse. So this case was, I think, as close to an isolated posterior STEMI as we could get. There's some reciprocal T wave inversion in AVL, but this is nowhere near a slam dunk, right? But if you shift your focus to the anterior leads, you see this ominous anterior ST depression, upright T wave, tall R waves, pretty tall R waves here. These are reciprocal changes to a posterior STEMI. The computer picked it up, but it said that it's an inferior MI, but I think the most recognizable features of this EKG is the anterior ST depression, which should then prompt you to obtain a posterior 12 lead and look for any ST elevation. Another interesting case. This was documented as a possible STEMI, but there's nothing possible about it. Look how massive these T waves are. They're broad and they're tall, and I think they're taller than the QRS complex right there. But I also want to point out, look at this ST segment here. You see how straight that is? So if we draw a line from the J point to the apex of the T wave, and that's a horrible, horrible line, but let me try it down here. If we draw a line from the apex, or from the J point to the apex of the T wave, so really, this is a straight ST segment. Dr. Almo-Matou refers to this as the Nike sign. So Dr. Almo-Matou is an EKG expert. He says when you see the ST segment start to straighten out, and when it goes like from concave to more straight, then that's some of the earliest changes you will see in a STEMI, is that ST segment starting to straighten out. So they ended up activating the cath lab on this patient, obviously, but there was ST elevation everywhere. There was obvious ST elevation. The J point is right here, and you can see there's many millimeters of elevation in V2 and lead V1. The heart rate was also low. And you have ST elevation in V1, which is pretty atypical of an anterior STEMI, unless you also have right ventricular involvement. So because V1 is a right-sided lead. We're going to move on now and talk about STEMI and bundle branch block. Some people might want to tell you that if it's a left bundle branch block, that you can't diagnose a STEMI, and that is patently false. You can absolutely, unequivocally diagnose a STEMI in a left or a right bundle branch block using a set criteria that we're going to discuss. So I want to read this quote from Emergency Medicine Journal in 2001. It says, ST segment elevation is perhaps the most demanding of the electrocardiographic features seen in the chest pain patient. It is demanding in that its presence must be explained, and if the etiology involves MI, urgent therapeutic decisions must be made. Unfortunately, ST elevation is not is a not uncommon finding on the ECG of the chest pain patient. Its cause infrequently involves MI. So, knowing that you can diagnose a STEMI in the setting of a left bundle branch block or a right bundle branch block, you now know that the onus is on us to know how to interpret those EKGs, and we are expected to make those decisions in the field. It's no longer, if it's a left bundle, we can't make the call. We've got to wait till we get to the ER. That is false. We are responsible for knowing how to interpret EKGs. So we'll do a quick review of left and right bundle branch blocks. A lot of people have different methods for determining whether it's a left or right bundle branch block, and I've heard them all, and a lot of them are very complicated. It doesn't have to be that complicated. First, all you have to have is a QRS complex that's at least 0.12 seconds or 120 milliseconds. If you've got a wide QRS and it's a sinus rhythm, then you have to ask yourself, do I have a bundle branch block? Or do I have a left or a right bundle branch block? To know whether or not it's a left or right bundle branch block, focus your attention on V1. So if you look at V1, I teach the turn signal method. If you turn a turn signal down, you're going left. But if you're going right, you turn your turn signal up. So if the QRS is negative in V1, it's a left bundle branch block. If it's positive in V1, it's a right bundle branch block. Some people use the bunny ears, but that is not the best way, in my opinion, because a right bundle branch block may have notching. It may have this RSR pattern, or it may just be one uniform QRS complex without the notching. Something else you have to understand about left bundle branch blocks and left ventricular hypertrophy and paced rhythms is the rule of appropriate discordance. So generally, in normal rhythms or in patients without a left bundle branch block or left ventricular hypertrophy, the ST segment and the T wave is generally in the same direction as the QRS complex. That's referred to as a concordant T wave or concordant ST segment. In paced rhythms, left bundle branch blocks or left ventricular hypertrophy, the rule is that the T wave is discordant. So the T wave is in the opposite direction of the QRS complex. So if you have a positive QRS complex, you would expect the T wave to be negative, or you would find a negative T wave. If the QRS complex is negative, you would expect or find a positive T wave. This is normal. So here's an example of a paced rhythm. If you look in nearly every lead, the ST segment and the T wave is in the opposite direction of the QRS complex. Negative, positive, positive, negative. Anytime you have a small QRS complex or it's equiphasic, so if you have equal positive R wave and equal negative S wave, then the T wave is often flat. So when it comes to diagnosing a STEMI and a left bundle branch block, in 2013, the ACC-AHA released guidelines for the management of a STEMI. And they stated that a new or presumably new left bundle branch block has been considered a STEMI equivalent. Most cases of left bundle branch block at time of presentation, however, are not known to be owed because of prior ECG is not available for comparison. New or presumably new left bundle branch block at presentation occurs infrequently, may interfere with ST elevation analysis, and should not be considered diagnostic of MI in isolation. Criteria for ECG diagnosis of acute STEMI in the setting of left bundle branch block have been proposed. That criteria that they are talking about was a result of the Gusto 1 trial, which outlined the ECG criteria with a high specificity and statistical significance for the diagnosis of an acute MI in a left bundle branch block. This is called Scarbosa's criteria. Now, Scarbosa's criteria seems pretty daunting. It seems complicated, but I think after looking at a few examples, you will realize that it's not as complicated as it seems. So the criteria is concordant ST elevation. So if the QRS is positive and the ST segment is positive, that gives you a score of 5. Concordant depression in V1 through V3. So in V1 through V3 in a left bundle, the QRS is negative. So if you have ST segment depression when you should have ST segment elevation, then that gives you a score of 3. Then if the QRS complex is negative, we expect the ST segment to be positive, but if the elevation is greater than 5 millimeters, then that gives you a score of 2. So a score greater than or equal to 3 has a specificity of 90% for diagnosing myocardial infarction. Now, a few years ago, Dr. Smith came along and said that the EKG is proportional, and we talked about proportionality before. Dr. Smith's theory is that if you have a very small QRS, so if you have a negative QRS that's really, really small, you couldn't possibly have a lot of ST segment elevation because the EKG is proportional. So he developed this criteria that is very sensitive and very specific, and Dr. Scarbosa herself even uses this criteria. So this criteria says that if you have one or more leads with 1 or more millimeters of ST elevation that is discordant proportionally, and he defines proportionally discordant or excessively discordant as greater than or equal to 25% of the depth of the preceding S wave, then that is positive for an NMI. So to simplify it a little bit, we can allow 1 millimeter of elevation for about every 5 millimeters of QRS voltage. So in this example, the QRS complex is 10 millimeters. So we have 5, so we'll allow 1 millimeter of ST depression here. And then we have another 5, so we'll allow a total of 2 millimeters of ST depression. So this is a patient that does meet the modified Scarbosa criteria. Here's a few examples. So here we have a left bundle branch block. We have discordant ST segment elevation in these leads, which we expect. We have it also, we have discordant ST segments and T waves in these leads, which appear relatively normal. But once we get over to the V4 and V5, you see that you have a positive QRS complex here, but you also have a positive ST segment. So this is an obvious STEMI in the setting of a left bundle branch block. And this patient gets 5 points. So this is an obvious STEMI in the setting of a left bundle branch block. And I don't think you would have, even if you didn't know Scarbosa criteria, you probably would have called this as a STEMI. Here's another example. This EKG meets all criteria. So all Scarbosa criteria and modified Scarbosa criteria is met on this EKG. You see you have concordant ST depression in the anterior leads, greater than 1 millimeter. You have concordant ST elevation, so the QRS is positive, ST segment's positive. And you not only have almost 5 millimeters of discordant elevation here, okay, but the EKG is, the ST segment is disproportionate to the QRS. So we have just over a 5 millimeter QRS complex. So by the rule that we've discussed before, we would only allow 1 millimeter of elevation. So we have almost 5. So this is excessively discordant ST segment elevation. On this EKG, you can go back to this formula for determining the ratio, but it's so obvious that you don't even need a formula. You'll see that the ST segment is more than 50% of the QRS. You'll see that the ST segment is almost as tall as the QRS, so it's definitely greater than 25% of the QRS. But on this EKG, you wouldn't even need that because you have a slam dunk concordant ST elevation here. Here's another case of a patient with a left bundle branch block who is having chest pain. Now, this paramedic thought that you couldn't diagnose a STEMI in the setting of a left bundle branch block, but she also thought that the EKG was definitely abnormal and erred on the side of caution and took the patient to a PCI center. Once they got to the PCI center, it was quite a while before the patient actually went to the cath lab because the physician read the EKG and thought that you couldn't diagnose a STEMI in a setting of a left bundle branch block and was looking for a previous EKG. The truth is that this patient easily meets Scarbosa's, Smith's modified Scarbosa criteria. It's an obvious anterior STEMI, right? You have more than 5 millimeters of ST elevation, and the amount of ST segment elevation is almost double the size of the QRS in V3. So this should have been a slam dunk case when it wasn't. Here's another case, but this patient had a pacemaker. The patient was having obvious chest pain, came into a non-PCI facility by ambulance, and I was called to transfer the patient for a STEMI. Now, the ER physician didn't know anything about Scarbosa's criteria, but he called the receiving facility, talked to the cardiologist, said, I have a patient with a pacemaker and a STEMI, and the cardiologist said, well, how do you know? The ER physician said, because I've seen a lot of EKGs of patients in paced rhythm, and this patient's having a STEMI. He didn't know how to explain it, but he just knew, and he was right. You can see that the patient has about a 5 millimeter QRS complex, okay? And the patient has more than 5 millimeters of ST elevation. So if this is a 5 millimeter QRS complex, then there should only be about 1 millimeter, let alone 5. And Scarbosa criteria and Smith modified Scarbosa criteria can also apply to patients in paced rhythms. So you can even diagnose a STEMI in a patient with a paced rhythm. Now, this is what a normal paced rhythm should look like. So you have this is a ventricular pacemaker, you have a wide QRS, and you have ST segment deviation that's opposite or discordant of the QRS. So this is a normal paced rhythm. And the ST segment elevation is not excessively discordant. So we have 5, 10, 15, almost 20, and we do not have enough ST elevation. It's really hard to see because we can't see the grid lines, but just by looking at it, it does not appear the ST segment elevation or discordant elevation does not appear to be excessive by my eyes. Now, a right bundle branch block. Can you diagnose a STEMI in a right bundle branch block? The answer is yes, and you don't need any special criteria. You don't need Scarbosa criteria. You don't need modified Scarbosa criteria. The answer is that there should just never be any elevation with a right bundle branch block. But sometimes you'll have an EKG like this where if you look in the inferior leads, you will see what appears to be ST elevation. All right? And it can be hard to know what's part of the QRS complex, where the J point is, and where the ST segment begins. So there is a nice little trick. So everything that is occurs at the same moment in time. So all of these complexes right here and all of these right here are occurring simultaneously. Okay? So if you look at all of these leads, if you look at V1, you can see there's a clear J point. So the J point is right here in V1, or lead 1. So if I take that, I draw a vertical line all the way down, and all I have to do is follow this thick line. If I follow that all the way down, I can see that the J point is right here, and that this is actually part of the QRS. Now, left ventricular hypertrophy. Myocardial infarction is not the most common cause of ST elevation in the emergency department chest pain patients. Left ventricular hypertrophy is most often responsible for EKG ST elevation, followed by MI and left bundle branch block, which occur at equal frequencies. Now, when I go to chest pain committee meetings, they generally share the false cath lab activation rate. And more often than not, it is due to left ventricular hypertrophy. And if we want to reduce our number of false cath lab activations, we need to learn how to diagnose left ventricular hypertrophy and how, if we can, diagnose a STEMI in the setting of left ventricular hypertrophy. So, what does left ventricular hypertrophy look like? Well, you will have the discordant ST segments, right? But there's another characteristic pattern, and it's referred to as a left ventricular strain pattern. If you look in lead 1 or AVL, you will see positive QRS complex, and you'll see this hockey stick pattern, strain pattern right there. So you'll see the J point right there, and then you'll see the T wave inversion, and the line in between kind of looks like a hockey stick. And you'll also see this in V6, okay? And then you'll see the inverse pattern in lead 3. Now there's some voltage criteria. So generally when the left ventricle is enlarged, that causes higher voltage on the EKG. Now to calculate the voltage criteria, you take the S wave depth in V2 or V1, whichever is deepest, and the R wave height in V5 or V6, whichever is the tallest, and you combine those together. And if the combination of those is greater than 35 millimeters, then that is left ventricular hypertrophy. Also, if you have an R wave in AVL greater than 11 millimeters, that is left ventricular hypertrophy. This was a recent case where it was called in as a STEMI. And when the patient got to the ER physician looked at it and said it's not a STEMI, it's LVH. So how do we know it's LVH? Well, first of all, you can see that in almost every lead, the T wave is opposite the QRS. And the QRS is not wide enough to be a left bundle branch block. Okay? Now we need to look and see if we meet voltage criteria for LVH. So the voltage in V1 or V2 looks like V2 is the deepest. If you add that to the voltage in V5 or V6, it doesn't appear to be nearly 35 millimeters. So there is 5, 10, 15, 20, 20 and some change, 25, 30. So it's very close. But if you look at AVL, you've got 5, 10, definitely more than 11 millimeters of QRS in AVL. But you also have this hockey stick pattern. So here's another example of LVH. There's a lot of elevation right here. So there's looks like almost more than 5 millimeters of elevation, ST elevation in V2, a lot in V3. But you also have huge voltage, huge voltage. The voltage even goes off of the page. and you've got that strain pattern in V6, strain pattern lead 1, and you've got T waves that are opposite the QRS in every single lead. So the question is, how do you know if it's an MI or not? How do you know if the patient's having a STEMI in the setting of left ventricular hypertrophy? The answer to this is that it's very difficult. The current theory is that STEMI in the setting of left ventricular hypertrophy is very, very rare, and that it's almost non-existent. And you can use the ST to S ratio, all right, to try to determine if there's excessive ST discordance. But the fact of the matter is that can be difficult. And the theory is that when you have a STEMI, the voltage decreases, right? When there's a myocardial infarction, you generally don't have enough voltage to actually meet left ventricular hypertrophy criteria on the EKG. So that, and that's so common that you never really see patients with left ventricular hypertrophy that are also having a STEMI. So long story short, if you see this pattern, think twice, call in your report, let the patient know there is ST elevation, but that you think it's due to left ventricular hypertrophy, and that you would like them to overread the EKG and make that decision when you arrive in the ER. As always, you can email me or call me if you have any questions or if you would like any of that clarified. I hope that it made sense. And if it didn't make sense, I at least hope that it piqued your curiosity and your interest, and that it will drive you to try to learn more about EKGs. But I would be happy to sit down and talk with you if you have any questions.